I'm Ken, in case you haven't worked it out, and that's Sam. Welcome, everyone. Very pleased to be here to present the findings of our project on the Rural Clinical Placement Project. Just before present, I just want to, acknowledge the whole concept of this forum. Having been involved in a few projects over the years, there's nothing more frustrating to get to the end of a project, fill in your final report and send it off to Brisbane or to Canberra or wherever it's going to have it put on a shelf. So I think that the whole concept of being able to share the ideas, the findings from a project is great. I'm conscious of the timing, and because we're in Queensland, we don't have daylight saving, so we don't have the hour and 12 minutes. I was told that we're supposed to be making an exciting and vibrant presentation, so as part of that, it was decided that I would step back and let Sam do that. So I'll hand over to Sam, who has been heavily involved in the project.
Thanks, Ken. After coming after Dominic, what am I going to do? Race up and down the stage, breathless and excitable? But no, not today. My name's Sam Freeman. I've assisted in the coordination of this project for GP Connections. Ken Murphy, our Managing Director, has overseen the management side, and Dr Patricia Stewart and Dr Tricia Rathie have been constant GP activity advisors and an invaluable part of this project. Innovation. Whew.
I'm the sidekick.
Don't get lost. Henry Ford once said, if I had asked them what they wanted, they would have said faster horses. And so it is with innovation. True innovation is serendipitous. It comes upon you, or you come upon it quite by chance. And this is what this funding has allowed us to do. We're all aware of the objectives of this funding. The remit was to come up with a project that increased clinical education capability and placement capacity, increased engagement with clinical supervisor support and/or training programs and providers, provided innovative clinical placement models, approaches, increased collaborations across the health provider continuum, created sustainable opportunities and growth for quality clinical training placements. Now, these can just sound like words on a page, bureaucracy at its best, but in reality, this was a true opportunity to create something meaningful and that truly supported these people embarking on clinical placements. We brainstormed with a group of GPs, medical educators and supervisors and developed what appeared to be quite a simplistic project to use technology to support registrars in rural locations. For instance, using Skype to host a supervision session. We wanted to link these registrars with more than their supervisors and really illustrate that being rural didn't necessarily mean being isolated. We saw this as a practical mirror of what was occurring in telehealth, with GPs linking for specialist appointments in places like Sydney or Melbourne. And augmenting this was the scoping of existing educational resources to support registrars and the GPs in these rural locations. We were looking at very specifically orientated education that targeted the rural practitioner and assisted registrars and indeed medical students to understand the realities of life in the bush. There's an awful lot of life as the thorn birds out there, but of course this was our faster horse, as you will find out. We established a project governance committee because we said we would. And we wanted true input from people on the ground. We wanted a touchstone for ideas, and we needed to have guidance as to the direction of our project. And our wonderful members included the UQ Rural Clinical School. They offer a practical and academic perspective on medicine in the bush and have a good overarching understanding of the education opportunities. The Australian College of Rural and Remote Medicine, need I say more? I love this place. It's a wonderful one-stop shop for all things medical and rural, and it houses the Telehealth online module and the resource directory for health professionals. The RACGP Rural faculty an unnerving amount of expertise in on-the-ground medicine in rural areas, linking in with all sorts of great resources. CSQTC, an amazing array of medical educators and supervisors who fall over themselves to assist their registrars and medical students. Their specialty also seems to be in the creative approach to education and thinking outside the square. And GP Connections, yeah, they're okay. Well, it is us, and we are all about GPs, so that's very helpful. Now, our aim was to meet every couple of months. We managed to meet via teleconference twice as a group, and the rest, I have to say, ended up being really ad hoc, with emails flying and individual phone calls made. It worked for us as it allowed us all input, and we did use our Project Governance Committee, but it just wasn't to plan. Our terms of reference stated that the objectives of the PGC were to provide GP Connections with the opportunity to share information and progress and gain ideas and feedback on the implementation of the Rural CP project, provide opportunities to identify linkages, to facilitate integration or sharing of activities and resources to reduce duplication across projects, and to provide an opportunity to identify and address issues and concerns. And that's what they did. In fact, that's what they're still doing, because we ain't finished yet. Before we go on, I want to touch on telehealth and why it created so much of a focus for us in the original design of the project. Telehealth is an important technological advancement for general practice, the AMSs, aged care facilities and communities in general in the rural areas. The opportunity for an Aboriginal person in Santa Teresa, Northern Territory, to come into the local clinic, sit down with their uncle, the Aboriginal health worker, and the locum GP and talk to the general physician in Alice Springs about their diabetes via the computer, it means the world to them. It could mean a life. And we wanted to extrapolate this experience and see if it could translate into the supervision of registrars in the rural areas. We knew that the Medicare locals had telehealth support officers whose remit it was to orientate general practice in rural areas to telehealth and the accompanying red tape, always a joy. There were also support officers through the Aboriginal and Torres Strait Islander community-controlled health services funded by NACCHO, and the telehealth education resources were numerous. The ACRM, the RICGP, NACCHO, and even some of the specialist colleges. So educational support for telehealth was not going to be an issue. What we didn't anticipate was the fact that whilst general practice and the services were walking down the road of telehealth, and whilst from a clinical perspective this was working well in places and not so well in others, the ability for us to work with the training consortiums to deliver supervision via this medium was dependent on infrastructure. The great barriers to new technology, or indeed old technology. Skype doesn't quite work in Quilpie, or sorry, we lost the connection, or we haven't got the facilities set up yet, or simply, I don't trust it. So that's okay. Let's backtrack. We had another idea. We had seen it as part of resources available to the registrars and the medical students. We did not see it as the linchpin or the way in, but suddenly there it was, the clinicians' network. We had to rethink and reorientate. Suddenly we were looking at the reality of baby steps. We needed to have a group of clinicians that had the expertise and the trust of the group. We needed experienced GPs with excellent communication skills to establish a relationship with the registrars, the medical students and their supervisors, and act as mentors, support crew, an entree into using technology as a means of support. The original vision had been to have this huge network, this pool of experts, but no, that wouldn't work. It needed to be small, familiar, workable, and constructive. We called a meeting, we identified some potentials, we honed the criteria, and 3 GPs put their hand up. It was a big task, a tall order, a time-consuming undertaking. We call it the virtual classroom. It is a place where registrars, medical students, or their supervisors can meet up, have a virtual cup of coffee, discuss a case in the strictest confidence, and then, if they want some more specialised conversation or assistance, they can Skype or talk via the mobile phone one-on-one with one of the network. And here they are. Dr. John Lamb, born in Roma, worked in Hewarden, northwest Queensland, and in Gatton. He's the past chair of GP Connections and is currently on the boards of Health Workforce Queensland and Queensland Rural Medical Education. His interests include aviation medicine, asthma, postgraduate medical education, and medical informatics. And he also flies a plane. He was actually on the television during the floods. That was his plane floating down Gatton. Very sad. It's okay, it was funded and he got it back. Hume has worked in Bundaberg and Toowoomba for the past 33 years. His clinical focus and special interests include addiction medicine, chronic disease, complex and challenging patients, of which he has many apparently, as well as practice management and clinical governance. And David worked in Brisbane hospitals for 3 years and later undertook the palliative care training fellowship at Mount Olivet Hospice and has completed a postgraduate diploma in palliative medicine through Melbourne University and has been a senior lecturer in the Rural Clinical School of Medicine UQ since 2003. Information regarding how to access this virtual classroom was sent out through CSQTC and QRME, and we have 17 active members at present. Each staff member is constantly involved, but they are officially e-moderating for a week at a time. This means that someone is in charge of generating the discussions, ensuring that people feel they can post questions and partake in discussions. We don't monitor these apart from administration queries, so that they can feel secure in the knowledge that they are part of a circle of trust. We were allowed to share this example of one of the cases the group is discussing at present to exemplify the kind of discussion that occurs. A 10-year-old girl with severe keratosis of her palms and soles, present most of her life and resistant to a range of topical medications tried in the past. And this is, they're talking about, so I've got how many minutes? Oh, geez. Okay. So I've been working towards the creation of the motor car, flashback to Henry Ford and his faster horse quote. And here we were with a decision to make. We'd scoped the existing education and we decided that no, there wasn't enough education out there that didn't utilise motherhood statements about the bush being a romantic place. An education resource needed to be developed that opened the registrar's eyes to the possibilities of the rural life and very important part they could play in it. We said to Queensland Health, what do you think? They liked the idea. So we've come up with an online education module. These are the sessions that are included in it. We meet Dominic, who's going through his rural rotation. That's Dominic. Am I over? Okay. Can I finish now? All right. And what was it we were saying about horses? Just when we were winding down, we had another idea, of course we did. Working in partnership with our aged care project, which you'll hear about later, we decided to stretch our dollar and we are developing an app that registrars and GPs can access via their phone or tablet. We're developing a suite of 5-minute topics that will be covered by a GP via video handbook web app, and they'll be available in the coming month. We'd like to thank the Department of Health, Queensland, for their flexibility in allowing us to switch goalposts and build faster motor cars. Thank you.